Dr. Jonanthan Rohrer, who has kindly agreed to come and talk to us for this second part of our meeting. So some of you may well know John already, either through your patient sort of clinical contact in the clinics, but thank you very much. We really appreciate having you on with us today. So enjoy what John has to say.
So I work here. I've worked here on and off for about the last 10 years. Starting as a junior doctor and finally getting to be a senior doctor as of the last month or so. And I did a PhD here and some research here. And I'm going to touch on a bit about the main study I work on here and that we work on actually now across the whole of the UK and in fact the whole of Europe. But Jill asked me to talk a little bit about an incredibly difficult topic because there isn't much to say on current and future drug treatment. So I'm going to start just by going back to some simple thoughts about what causes dementia. So I use the term dementia to mean a whole group of conditions, of which Alzheimer's disease is the most common, and for the vast majority of dementias, this is the process that's happening. So why does it start? I don't know, for the vast majority of people, but for some people there's a genetic cause, and particularly in FTD that's more common than Alzheimer's disease. So in Alzheimer's disease, most people don't have a whole group of people in the family that have it. It's not something that runs from one generation to the next. Whereas probably in about a third of people with FTD, it will run in the family. But for those other 2/3 of people, we're not clear why it happens at the moment. But whatever it is that kicks it off, we end up with, we're all made up of proteins and lots of thousands upon thousands of proteins that help our cells work. And for some reason or another, we end up with some abnormal form of a protein sitting in the brain. So our brain cells usually move proteins between the brain cells very easily, but they get folded into a funny shape. And if they get folded into a funny shape, they can't actually move between the cells. And so what a brain cell does when it's got a funny protein sat in it is it just dies, and we lose brain cells. And that's really the process that's happening. Something that triggers it off, you get these proteins folding into a funny form, they can't pass between the brain cells, and so the brain cells are lost. That's what we can see on a brain scan sometimes, that loss of brain cells, or we sometimes use the term brain atrophy. And when you lose brain cells, the way that our brain cells send messages to each other is by chemicals. So one cell to the other, there's a little gap in it between one cell and another, and it sends a little chemical to the next cell and says, you need to work. And if you lose brain cells, then your brain chemical levels start to be altered and start to be different. And usually they go low because you don't have enough of a particular brain chemical. And when you've lost cells, and when you've altered all these levels of the brain chemicals, you start to develop symptoms and signs of the disease. So how does that relate to FTD? Well, if we look at that same process, well, we know a little bit about genes. So we know particularly about these 3 genes now, called progranulin, tau, and C9orf72. These always have funny, difficult, long names, unfortunately. And those are the genetic causes. We don't know much about non-genetic causes. We don't really know why it kicks off in other people. And then again, there are some funny names of proteins that are sat in the brain. And those are called those things, TDP43, tau and FUS. Again, difficult names for things. But they, of course, you lose brain cells. You lose brain cells particularly in the front, and the side, so the frontal and the temporal lobes. That's why it's called frontotemporal dementia, because you lose the brain cells specifically in the front and those side bits. And we'll come back to this, but we lose the brain chemicals, particularly of a brain chemical called serotonin. Serotonin you might know about because that's something that's altered a bit in depression. And we use some of the drugs that change serotonin levels in depression. And that, of course, leads on to behavioural problems and language problems in some of the forms. So that's important because it makes us think about, well, how do we treat FTD? Well, in an ideal world, we would change those risk factors. We'd find out what those risk factors were, and we'd be able to stop them, or we'd be able to change them, or we'd be able to change the genes. We're well away from being able to do that. We might prevent the formation of those proteins, or get rid of those abnormal proteins. So try and stop us in that bit before we actually lose any brain cells. We might prevent injury, so when those proteins might be there, but we might be able to stop them from doing damage to the brain cells. Obviously, the further we go along, the less good the treatment is likely to be, in a way. So we don't want to just alter the levels of brain chemicals, because even if we alter the levels of brain chemicals, if all that's still happening on the other side, then altering the level of brain chemicals won't stop all the stuff happening over on the left-hand side. And of course, what we do now, which is really manage the symptoms, and there are lots of ways in which we can do that, but obviously none of those are ideal. And really what we would like to be doing is moving from where we are now, which is far over to the right-hand side, and try and push as far back over to the left as we can go. So where are we now? Well, now we can move a little bit over to the left, which is we can do a bit about altering levels of brain chemicals. So there are these group of drugs which are called SSRIs, or selective serotonin reuptake inhibitors. It's a funny name. That means that they just increase the levels up of this transmitter called serotonin. And these drugs were designed initially to be used as antidepressants. So these are drug names that you might know just because they're names, particularly Prozac. It's common, lots of people know about that, but these other drugs as well are drugs that are designed as antidepressants. There are some small studies, and as we go on, you'll see that this is a recurring theme, which is that there aren't any very good drug trials in FTD at all. So there are no large drug trials that say this drug might be good, this drug might be not. And the problem is when you do very small studies, and by small I'm talking about 10, 15, 20 people rather than hundreds of people, is that you get a not clear answer on things. So you might get a positive result in one but a negative result in the other, and we're not quite sure what exactly does that mean. So the studies that there are, and I put those on for anyone more medically inclined to have a look at them, but basically a couple of other points I make is that actually these studies were done back in 2002, 2003 and 2004, meaning we haven't really done many other studies for 10 years in these drugs. But there are a very, very small amount of evidence that some behavioural symptoms might improve with these drugs. So there are some doctors that will give these drugs, SSRIs, to people with behavioural variant FTD, in the sense that there might be, and maybe for a short period, some benefit on behavioural symptoms. If we go backwards, if we increase the levels of serotonin, then it may help behavioural symptoms for a short period, but it's only going to help for a short period because everything that's happening over on the left-hand side is still happening, in the sense that the abnormal protein is still forming, the cells are still being lost, and so there will come a time when, however much you alter levels of brain chemicals, it isn't going to help very much if everything is still happening that's over on the left-hand side. So, serotonin is one of a few different brain chemicals. Perhaps one of the most well-known is one of the chemicals called acetylcholine, and the reason that's well-known is because that's what's abnormal in Alzheimer's disease. And it is the mainstay for treatment of Alzheimer's disease currently in this group of drugs called cholinesterase inhibitors. So these drugs, they've always got two names, because there's one that's the name that's made by the drug company, and there's one which it's just known as in general. So you may know some of these names, things like donepezil or Aricept. These are drugs that are particularly used in Alzheimer's disease. And drug trials in Alzheimer's disease, and also in another form of dementia called Lewy body dementia, clearly show that they have some benefit, and benefit on memory, benefit on general function. The problem is that because they're available and they're there, they are commonly used in people with FTD in the hope that they might have some benefit. The problem is that there are no actual studies that show any benefit whatsoever of acetylcholine and cholinesterase inhibitors. So there's only one large study, and the ideal, the perfect study in medicine is what's called a double-blind study. That means a study where you don't know what drug you're getting, you don't know if you're getting the drug or a placebo, and neither does the doctor examining you. So you're blind to it and the doctor's blind. And in the only double-blind study, there was actually no evidence for benefit of one of these drugs. And one of the more worrying things of this is that in another study, actually some people got a bit worse on cholinesterase inhibitors. Not everybody, but some people got a bit worse. So the disinhibition and the slightly compulsive, obsessive behaviours actually got a little bit worse on cholinesterase inhibitors, although that deterioration actually deteriorated when those drugs were stopped. So the difficulty we have is that these drugs are readily available, and they are sometimes given to people. But when we actually look at the research available, there really isn't any evidence that they benefit, and a very small amount of evidence that definitely in some people, not everybody, they may actually make things a little bit worse. The other transmitter that we should think about is something called dopamine. And dopamine, the drugs that work on dopamine are those drugs that are more commonly used to treat people who have what's called a psychosis, or the most common form of that being a condition called schizophrenia. So these drugs are sometimes called antipsychotics, because they work in schizophrenia. That was the reason why most of them were developed. And again, you might know some of these names. They are much more commonly used in later stages of FTD, and can be helpful to help with fairly severe behavioural symptoms. And again, the problem is there haven't been many trials of them. There is one study which does show that they may be of benefit. So they're definitely used, people use them for behavioural symptoms, but there's only one real study that shows that they might have some benefit. Now, the one problem that there is, and I've definitely been to meetings like this before where people have told me this, in fact people told me this before there were ever even studies in it, is that sometimes some people just seem to be a bit sensitive to the side effects. So, dopamine is helpful to our movement, and if we change the levels of dopamine, it can make people a little bit stiffer and a bit more rigid, a bit like you've got Parkinson's disease. And some people, it does seem that there are now a couple of studies that show that there are a group of people with FTD that if you give them these drugs, they can be very sensitive to those side effects and so become a little bit more stiff and a bit more rigid. So the evidence for this is small, they're definitely used, and people say that they can be of benefit. They can really help sometimes in just slightly changing very severe behavioural problems, but they do come with that slight risk of people being a bit more sensitive to the side effects of them. And of course, no large trials to show that they help. So those are the sort of three main classes of drugs that are available, that people use. They're all drugs that alter the levels of brain chemicals. The ones perhaps with the greatest evidence are the ones that affect serotonin. The ones that affect acetylcholine, the ones used in Alzheimer's disease, really have no evidence for their use. And then the ones that affect dopamine are really somewhere in the middle, perhaps a little bit of evidence for their use, but again, possibly some side effects from them. And that's really where we are in terms of available drugs currently for FTD. So I'm going to talk just for a few minutes about where we're heading. And where we're heading is really towards the left-hand side. So we don't want to just alter levels of brain chemicals. We know that's not going to have any long-term effect. And we want to try and move over to the left-hand side and think about how we might, and the most common way of thinking about it at the moment is how do we actually prevent these abnormal proteins from forming in the brain. So there are two ways that people are doing this at the moment. The most promising way is actually for people who have a mutation in this gene called progranulin. And for people with progranulin mutations, we have a slightly better idea of what that pathway is. So if you have a problem in the progranulin gene, that causes decreased levels of the protein called progranulin. And so the theory being that if you can increase progranulin levels back up to normal, that might prevent the deposition of these abnormal proteins in the brain cells. And in progranulin, people end up with this funny protein called TDP43. And so the stage we were at about a year or two ago was that people had done studies in cells, in dishes, and looked at what drugs might increase progranulin levels. So all of these 4 drugs are actually drugs that are used for other things, but people have been found to increase up your progranulin levels. So chloroquine is actually an anti-malaria drug. Amiodarone is a heart drug. Modipine is a heart drug, it's a blood pressure drug. And vorinostat is a cancer drug. So they're all things that are used for other things, but have been shown in cells to increase up progranulin levels. So actually, there is a small study in 5 patients of amiodarone. It's only 5 patients. You need to be doing much larger studies than that, but it didn't show any differences in progranulin levels or really change how people did. I have a small plug for my new website on this, which is FTD Talk. FTD Talk is, we started this about 3 or 4 months ago. FTDtalk.org. It is aimed at producing very short 2 or 3 paragraph summaries of research for lay people. It's aimed at, I have recruited a group of researchers from around the world who do FTD research, and they are all providing summaries, usually once every week or 2 weeks, on up-to-date research. The idea is that we will try and write it in as simple a way as possible, and try and keep everyone informed about what's happening in FTD research. So there are actually 2 planned studies. So there's actually a small study happening in the US already of this drug called nimodipine. There's a planned study of a drug, so similar to that drug that's called vorinostat. It's got a funny name, it's called an HDAC inhibitor. There will be a study of this drug only in people who have progranulin mutations. So this is really hopeful, particularly hopeful in people with progranulin mutations. They're small studies at the moment, but they're obviously very hopeful. The other thing, so we said there are these couple of proteins that we find in people's brains, and probably about 40% of people will have this protein called tau in their brains. And there is one drug that's now being trialled for this, that in cells, when you look at brain cells, this drug prevents the formation of abnormal tau. It's got a very funny name, but actually it's the same drug as something called methylene blue. Methylene blue, you might know as a dye. It's sort of a blue dye, and it's been used over many years in medicine because it does a variety of things. Again, it was many years ago. It was used as a malaria tablet. It's been used for a whole variety of things, but in a slightly different form. It's now being trialled in FTD. The interesting thing is that there are also some studies that suggest that it affects the other major protein that's affected in FTD called TDP43. So this is actually a trial that's being run by a company called TauRx. So I think if you look up TauRx on the internet, you can go to their website and look at this. This again is a study that we're doing here. It's being done in a couple of centres across the UK, and it's particularly, in fact, only for people with behavioural variant FTD. So that is still a study that's ongoing at the moment. And so again, I can give people a bit more information if they want about that. So I gave this talk, a similar talk probably 7 or 8 years ago in this group, and there was nothing. I mean, there really was nothing. So really we are moving forward, and we are moving forward to doing clinical trials. And whereas previously people weren't hugely interested, drug companies weren't hugely interested in treating FTD, it's become very much more of interest to drug companies, and so there are a lot of people and drugs in development. So the fact that we are actually moving into the stage where we're doing clinical trials is really hugely encouraging. So this says, can we prevent this pathway? But actually the question is, when's the right time to give treatment? What all this suggests is that we should be trying to treat FTD as early as possible. Now, we should be trying to treat that as early as symptoms develop, but that picture suggests that what we should be doing is actually treating even before symptoms develop. And in the genetic forms, that might actually be possible. That's why we set up a group called the Genetic FTD Initiative, or GenFI, which is a group of centres across Europe and in fact Canada who are working on genetic FTD. So it's led from here, and these are all countries and places that are currently involved in that, which is most of the research centres across Europe and Canada who are now involved, about 20 centres who are now involved. And the major aim of this study is to firstly try and show whether there are problems before symptoms develop. Secondly, to show what those problems are, and of course, the key goal is to try and find some treatments, and actually preventative treatments. So try and actually prevent people from even developing FTD in the first place if you carry one of the genetic problems. So future is unclear, but there are finally now some drugs that are attacking FTD from different perspectives entering clinical trials. That's hugely, hugely encouraging, something I wouldn't have been able to say 2 years ago in this talk. And we'll also now have these, what we sometimes call prevention initiatives, so trying to prevent FTD in genetic forms. And GenFi is slowly growing, and we're slowly getting more and more people involved in that. So virtually all of the people involved in that are actually children of people who have one of the genetic forms of FTD. They're often well people. The youngest person in the study is 21, so probably 20 or 30 years before they might develop symptoms. So really important to have people across all those ages to try and work out what's going on at all of those different stages and when actually problems actually start. So we're encouraged by what's happening, and it's good that these trials are happening. We really need to have more and more trials to happen, but it's definitely good news at the moment. So we have a huge amount of people involved in our studies, and it's only due to them that we managed to get any work done. These are my colleagues at the Dementia Research Centre, many of whom, if you come here, you will have seen. And of course, we hugely rely on funding, and in the UK, that's mostly from National Institute of Health Research, EMRC, and the Wellcome. So, happy to answer any questions. I'm sorry that was a lot of information, but happy to answer any questions on it.
Can I just ask about one other drug which my husband's been on? I mean, when he first came here, he was suggesting he had Taraprab. That's obviously, you don't have that in the list.
It's one of the SSRIs.
That's what Jason Warren suggested.
Yeah.
So
that's one of the serotonin drugs.
Yeah.
I didn't put them all. There's actually a long list of them.
Okay. When he started off with that, he's on 40 milligrams. He went through about a year ago when he was really unmanageable, and we also saw Richard Perry, who's also doing this trial you're doing, because he's at
the Tau trial.
The same one as you're doing here. And then he put him on Quetiapine, that's right, which we sort of kept increasing because it was just trying to dampen off these behaviour symptoms. And he has gone on sodium valproate, which you didn't put up as one.
Yeah.
Now, we are actually almost bought him, I think he's off it now, this week or last week, Quetiapine, because he's now in a home. And actually, I don't think the Quetiapine actually did an awful lot. Apart from it's like a kosh, everyone said, and it made him tired, like you say. It's very difficult to say that it did anything, but we were at the point when we didn't know, we almost wanted just to, we just wanted to give him something to somehow control him. He was uncontrollable, really. But I found that by being in the home, with the care and all the sort of tension around him, he's really relaxed. Yeah. And we've been slowly bringing him off. But we have put him on sodium valproate. Where does that fit in?
Well, I mean, I play down this sort of, I have one box that says manage the symptoms, and of course that encompasses the entirety of what everybody does. I mean, I don't mean to play that down, and there are lots of useful things that we can do, and as I said, with these drugs, with the dopamine drugs, I mean, they're used across all dementias as a way to cope with behavioural symptoms.
What is that?
Sodium valproate is a drug which was originally designed to be an anti-seizure, an anti-epilepsy drug. Yeah. That's its main use. It's been used in in some of the psychiatric disorders, so as what's called a mood stabilizer. So particularly its first use for that was in a condition called bipolar disorder, manic depression. How it works as a mood stabilizer when we think about transmitters is not completely clear, because it's probably not in the same way it works as an anti-seizure medication. Some of these drugs have multiple effects on different transmitters, and there are, the difficulties for all doctors is that they're living in a vacuum of drug studies. They're living in a vacuum of no studies that says what's the best drug to try. There are no studies at all of sodium valproate in FTD. And so what you're saying is, look, actually, some of the symptoms are similar that people get in bipolar disorder, some of that sort of mania in a sense, that's very similar in a way to some of the symptoms people get in FTD. So why don't we try a drug that's used for something else? That's the reason why all these different drugs have been tried. None of them were designed for people with FTD at all. The serotonin drugs were designed for depression. These were designed for psychosis and schizophrenia. Valproate is designed as a seizure medication that's been used in bipolar disorder. So it is trial and error. Yeah. It is trial and error, and people who have to rely on anecdotes. And I tried this in one person, it was helpful, wasn't helpful in another person. It really is that difficult at the moment.
Difficult. No, I wouldn't really be able to say whether they helped, because like you say, they're declining. So how do you know the drug's helping?
Yeah.
You just felt you had to do something. And actually when I saw Richard Perry, like he's off to Qatar, but Richard Perry said, in his opinion, he thought the one drug which probably is doing the most is the citalopram, which is because it's the serotonin.
Absolutely, and exactly. That is, as I said, it's the one with the most evidence. These drugs, these SSRIs, are definitely the ones with the most evidence for why they might work.
But then we had Hilda Hilo, who came here and did a talk. So we had the talk in March, who does, I think she's head of Dementia UK, isn't she, or something? And she came and saw me because she's also doing a PhD. And she said in her experience, the drug she found was doing the most was sodium valproate. And she thought the quetiapine wasn't doing anything.
The problem is
actually quite what they call a bit like a dirty drug, because it has definitely.
But the problem is, that's as with all clinicians and people working in it, it's all anecdote. It's anecdote for her. She finds it useful in a couple of people. We need to do trials in hundreds of people to show that it is better in more than one. Clinicians rely at the moment on these very small studies and anecdotes.
I just wanted to know why historically has there been so little research on FTD? Is it just now that the government and the West want to find out, right, so many people have varying kinds of dementia, and suddenly they are waking up to the horror of it?
There's probably an entire lecture on the answer to that question. So in a short space of time, of course there are in dementias in general, of course the governments have realised it's something important to them for a variety of both unselfish and selfish reasons. Governments are interested in it, but from an FTD point of view, if you think that I sometimes show when I go to academic talks, I show the number of research papers that have been published. When I started doing my PhD in 2005, there were about 250, 300 papers per year on the topic of FTD. Last year there were about 2,000 per year. The reason for that is that we know much more about it. Tau mutations as a cause of FTD were discovered in 1998, progranulin in 2006, C9orf72 in 2011. These abnormal proteins were discovered in 2006, TDP43 and FUS in 2008. And so actually these studies that allow us to know what direction to head for treatment have only been known for 5 or 6 years.
And is that along with the development of technology?
A lot of it is to do with, particularly the genetics, is to do with genetic technology. So if you remember the search to look at a single person's genome, our entire genetic code, that cost That was done in the Sanger Institute in Cambridge and in the private, a guy called Craig Ventnor in the States. That cost them a few £1,000,000 to do it. The cost to look at your entire genome now from a blood test is probably about £1,000. And that was the turn of the millennium. So it's changed from a couple of £1,000,000 to £1,000 to be able to do that kind of genetic screening. So genetic technology has hugely changed, but also just the way that people think about dementia, I think, has changed. I always remember I started as a house officer junior doctor in 2001, and the guidebook for junior doctors that was published by the Oxford University Press said, once you've made a diagnosis of dementia, there's no point in working out which one it is, because as it's entirely futile. And so that was very much the point of doctors' dementia. Not going to really think about it anymore. So thinking about things as, is this Alzheimer's disease, or is this Lewy body dementia, or is this frontotemporal dementia? Actually, in the sort of general medical population, that's just changed hugely in the 14 years I've been a doctor, and people are much more interested in working out where we're going, because that's helpful to tell people what's likely to happen, but also helpful for us to get people towards the right drug trial.
Can I just ask, are there any geographical indications of where there's a frequency of FTD or any Alzheimer's? Is it European, Western, East? I mean, anything?
So that again is an entire lecture. Perhaps the easiest answer to that is to think about the genetic forms. So the genetic forms are very variable geographically. There is a particular mutation in the tau gene which comes from North Wales, and it's very clear. There's a study that's looked at it, and it's more common often seen in the Liverpool and Manchester FTD clinics than it's seen in us down here, because a lot of people stayed around North Wales and moved into around Liverpool and Manchester. And its origin is, people can trace its origin back to a few hundred years ago. But these mutations sort of spring up in various places and then get spread around. So there's a very interesting story about this new gene called C9orf72. In Scandinavia, so I said when I said that about a third of people with FTD have got a genetic mutation, probably about, in the UK, about 10% of people who have FTD have got a mutation in this gene called C9orf72. In Scandinavia, it's going up to about 40 or 50% of people who have FTD actually have a problem with this gene called C9orf72. And what is interesting is that it appears to exist mostly in countries that the Vikings went to. And there is a current theory that this particular gene mutation has been spread by the Vikings. And there's sort of ongoing arguments about which countries the Vikings managed to make it to. So, in fact, we've just written an article for one of the big journals, a review article. And,
so it's Western, everything.
Yeah. But they're saying that there are slightly different forms though. It is seen in Japan. My wife's father's new wife's mother has FTD in Japan. So it definitely happens in various places, but it's probably just not well studied in other countries. That's active research in that kind of area.
And I mentioned earlier we had a question about how you, if you can at all, kind of predict a sort of time span.
Once the symptoms start to present,
yeah,
is there any sort of general time span?
The answer to that is difficult, and we don't have a good answer to it. It is variable from the different forms. So for instance, semantic dementia, semantic problems, that's probably the condition that lasts the longest from symptom onset. And if I looked at the group of people that we have seen, which is about 100 people over a 20-year period, the average time between symptom onset to death is somewhere around 13 or 14 years. Some people living up to 18 or 19 years. And that's by far the longest. The shortest is when people develop associated motor neuron disease, and that is only about 5 or 10% of people with FTD also get that, often get it quite early on. But there we're talking about a few years as an average between symptom onset and death. In between that, it is very difficult to say what the answer is, and it is very, very variable from person to person between those two forms, which are perhaps the shortest and the longest forms. So very difficult in between that, but essentially somewhere.
I thought you say it's onset of symptoms rather than diagnosis. So it can be, because we don't know when the symptoms.
Yes. That is always the case in our research, because we rely on people to tell us when they think symptoms started, but it's actually difficult, of course, isn't it? I mean, it's what is it that you say was the first symptom? Actually, looking back, I mean, that is hard. It's very hard. So it's an inexact science to say when people develop symptoms. We look at that just because diagnosis is variable, but the vast majority of people will get a diagnosis within a few years, and of course some people get diagnosis sooner, some people get diagnosis much later than that, but again, on average, most people it's usually a couple of years between symptom onset and diagnosis when people will get a diagnosis.
I was asked one question about genetic side, which is what my daughter asked me. There's nobody in our family who appears as though they had it. My husband's got it. His parents died, they're quite elderly. His mum was 94, his father was 86, and his sister is 13 years older than him, and she seems fine. His brother died when he was only 40 from an accident. So I sort of reassure my daughters that, there's no evidence. And then she says to me, but what happens if we're the first in the line? What happens if Dad, she said, we weren't like from Adam and Eve, someone's got to start.
They do, but we very rarely see that nowadays.
So you've gone further than that.
These are, they have a funny, they're often called de novo mutations. That's just Latin for new mutations. So these new or de novo mutations don't tend to happen in FTD. We don't tend to see people with them. The vast majority of people will have had, if they've got progranulin, tau or C9, they will have a parent that
in our case, it's unlikely if they're that age.
It is unlikely if they've got to that age. Of course, some people die young, some people die before they will get it, and it is unlikely. If I think about the very first research paper that was published on progranulin, they found a single person who had died at 80 who carried the gene but hadn't developed symptoms. That means that there are likely to be, it isn't 100% of people that will always have a parent that has it. Obviously you can get to an older age for some reason or another without developing symptoms. So it is very unlikely if both of your parents have developed, have got to an old age without it.
But not inconceivable.
But not 100%.
We've got time for one more question.
Yeah.
Thank you.
Can I just ask about the media publications recently connected with Alzheimer's, where it's suggesting that it's almost a lifestyle thing. If you keep fit and healthy and eat healthily, you won't develop Alzheimer's, and that really sort of upsets me because it's almost as if people who have dementia, maybe haven't looked after themselves, they always just mention Alzheimer's.
Yeah.
But, I mean, is it true with Alzheimer's? Is it true with FTD? Is there any indication?
So the answer is it's clearly not true in Alzheimer's disease. It's if only those risk factors were just what we ate and what exercise we did, that would be great for Alzheimer's disease. But it clearly isn't that. It's a complex mix of genetics and various other things. So it clearly isn't just that. Saying that, because there is a sense that one of the risk factors for developing Alzheimer's disease is around things like what your blood pressure is and whether you've got what we call vascular problems, so have you got diabetes or other things. And we know that there's a link of those things. So it's a stretch, isn't it? So one of the risk factors for developing Alzheimer's disease is having high blood pressure and diabetes. One of the reasons why people get high blood pressure and diabetes is because of diet and lifestyle. And therefore, the media does the opposite backwards, which is a fine diet and lifestyle stops you going the other way. You see what I mean? There is a connect there, but to say that it's all connected is untrue. And that's not going to be the case for FTD. I don't think.
Okay. So if it is in your body, could your lifestyle, something in your lifestyle, spark you off?
It depends on what you mean in your lifestyle.
Well, and you think look after yourself could spark you off that might not bring it to the fore otherwise if you look after yourself.
Or traumatic events, that's another thing.
Yeah, so all diseases that we get are a mixture of a genetic risk, and so our genes, things that we have, and things that happen in the environment. So the easiest example of that is lung cancer. The most annoying thing that people see on TV are those people who say, I've smoked 20 a day through my life, I'm 90, I've managed to survive, therefore smoking is fine. It's likely that those people have some amazing genes that are preventing them from either preventing them or don't have the same risk factors for lung cancer as other people. If you smoke 20 a day for 60 years of your life and you've managed not to get lung cancer, then there are likely to be some genetic things that preventing that from happening. So if we take that in dementia, it is likely that there are some both protective risk factors, so things that might protect you from developing dementia, but also things that put you at a greater likelihood. And therefore there are things in what we call the environment, in our lifestyle, in what we do, that might move you somewhere along that way. So I'm talking about people who don't have a direct gene problem. So then the sort of 70% of people that don't have an actual gene problem. If you've got an actual mutation in a gene, you're going to get it. But these are talking about what we call sporadic disease, this sort of 70%. So yes, there probably are. What those things are. So is head injury a risk factor? Might be, I don't know. There isn't any great evidence for it. Is diet a risk factor? I don't know. Might be. Is what your blood pressure is? It is for Alzheimer's disease, but is it for FTD? I don't know. I mean, it's likely that the answer will come from something like this. And do I know the answer to that at the moment? No.